Okay, good evening. I think we can get started. Great to see you all here this evening. Provost, Vice Provost, colleagues, friends and guests, and I'd particularly like to welcome Edna's husband Brian and daughter Becky. You're all very welcome. And it's really a great pleasure and honour for me to introduce Edna Roche, Professor of Paediatric Endocrinology, who's giving her inaugural lecture this evening. An inaugural lecture is one of the most enjoyable events in the academic calendar. It's a moment to celebrate the career of someone who's made a profound and lasting contribution to their field and to the university. It's also a chance to get to know the person behind the title, and in Edna's case, that person is truly outstanding. Many of you will already know Professor Roche as an internationally respected clinician scientist, educator, and an inspirational leader in paediatrics and child health. But what has always stood out most to her colleagues, students, and collaborators is something less easily captured on a CV or in her brochure. It's her warmth, her integrity, generosity, and the humanity she brings to everything that she does. Now, some of her greatest supporters were sadly unable to join us this evening, but I can honestly say I've never had colleagues so anxious to send on their best wishes. And one of whom, for example, has worked with her for 25 years, described Edna as, quote, highly collegial and supportive colleague, a dedicated mentor, offering thoughtful guidance and encouragement to students and trainees alike. And another has said, it's been a very great privilege and a pleasure for me to have known and worked with Edna for many years, who was a wonderful colleague and friend. She's an outstanding clinician, researcher, and educator whose contribution to paediatrics and child health has been exceptional. And she is admired for her leadership, meticulous organization, and genuine kindness. A generous colleague with warmth, humor, and an unwavering commitment to her patients and students alike. So Edna's path into medicine and academia reflects not only intellectual curiosity and excellence, but a lifelong commitment to improving the lives of children and families. Over the course of her career, she's developed an international reputation in pediatric endocrinology, particularly in childhood diabetes, a field that, thanks in no small part to her work, has been transformed in Ireland. And just to mention one, her leadership in establishing and directing the Irish National Childhood Diabetes Register has created something unique and enduring, a resource that not only supports research, but has changed how care is delivered nationally. It provides the evidence base to guide policy, to improve quality of care, and to give children with diabetes a better start in life and prevent serious complications through earlier diagnosis. But of course, Edna's research extends far beyond Ireland. She's a collaborator in key European research networks, including Eurodiab and the, I never can get this, Hevidor study group, is it right? Swedish, not so great, and on childhood diabetes, where her contributions help shape international understanding of childhood diabetes and its care. She's also built national and international collaborations in rare diseases, including Prader-Willi syndrome and congenital hypothyroidism, developing specialist services and research cohorts that simply did not exist before she took them on. Now, Professor Roche's publication record and research funding speak for themselves, as does her string of awards, keynote speeches, strategic initiatives, and appointments to advisory positions. But what's particularly striking is how much of this work has been built while maintaining a heavy clinical load, a reminder of the reality of academic medicine in Ireland, where innovation and impact are often achieved through sheer determination, collaboration, and commitment. And a fellow clinician of yours highlighted how she has, quote, she has made a real impact in the lives of thousands of patients and their families with kindness and compassion, meticulous skills, and a drive for innovation to make things better, unquote. Edna's contribution to education has been equally transformative as a dedicated and innovative teacher. She was instrumental in developing the undergraduate pediatrics curriculum, in creating structured systems-based tutorials and simulation-based teaching, and in establishing the first clinical skills laboratory for the Faculty of Health Sciences. That innovation turned out to be visionary. It became central to maintaining clinical teaching during the COVID pandemic. She has also created and directed postgraduate programs, including the MSc in Pediatrics and the MSc in Health Services Management, which I know is a story in itself, extending her impact far beyond her immediate discipline. Her excellence in education has been recognised through 2 Provost Awards for teaching excellence and curriculum development, a fitting acknowledgement to her influence on generations of future doctors. But if the academic record is impressive, and it is, it's what her colleagues say that paints the fullest picture of Edna, some of which I have already mentioned, but perhaps the most apt is, quote, "I could not ask for a better colleague, mentor, or role model. She is fully deserving of her recognition by Trinity, and I'm sure will continue to inspire many more young doctors to follow in her path." So tonight is a chance to celebrate that and to look ahead to what comes next. Because if there's one thing we know about Edna, it's that she's far from finished. Her work continues to shape how we understand, teach and deliver child health in Ireland and beyond. So ladies and gentlemen, it gives me great pleasure to introduce Professor Edna Roche, who will deliver her lecture, Sweet Child of Mine, The Changing Face of Diabetes.
Thank you so much, Brian, for that lovely invitation. I'm not sure who you were describing. It doesn't feel like me, but thank you so much. I really appreciate the opportunity of being here tonight with a captive audience. You can't ask any questions, and I can talk for as long as I like, so I'll probably finish at around 10. Thank you, Provost, Vice Provost, colleagues and dear friends for coming this evening. And I'd like to thank my parents and my family for their unwavering support. I plan to tell you a little bit about how I started in medicine, my early training, touch a little bit on my work and the collaborations in endocrinology, and then focus on diabetes in children and some of our research with the National Register that's now in its 18th year. So, in the beginning, I am a proud Trinity graduate. Came to Trinity in 1980, and some of my classmates are here, and thank you so much for coming. I came to study medicine with a view to being a paediatrician. I made great friends in Trinity, and we had an amazing time in pre-med, and it was so amazing that some of us, including me, decided we'd do it again, which we did. We then moved out to the hospitals and our clinical training, and after a few years on campus, moving around, we moved out to clinical training, and we chose to go to a small hospital because we kind of rightly figured we needed to have a close eye kept on us. So we selected to go to the Adelaide, and we had the privilege of being nurtured by some really great clinicians while we were there. We'd Colm O'Moran, Ian Graham, Gerald Tompkin, Mike Hutchinson, Eddie Martin, Frank Keane, Arthur Tanner, John Bonner, Paul Bowman, among others, so really fantastic people. We also attended at the Meath, St James's, the National Children's, and St Patrick's Hospital for psychiatry. So then we qualified in 1987, and we interned at the Adelaide. And in the Adelaide, we were required to live in to provide additional cover at night. So just before we started, the Adelaide told us that they had enough money to pay for 10 interns instead of the 11 of us. But the Adelaide being the Adelaide, when we said, look, will you employ us all and just split the salary 11 ways? No problem, they let us do it. So we had great times in the Adelaide, we had great fun with legendary parties and had great support from each other as we started to train. And please ignore that wonderful hat. So after we finished in the Adelaide, I started to do postgraduate training at St Vincent's in Allen Park, and I worked first as a casualty officer. And I don't know if you remember at that time, in order to save money, they decided in their wisdom to introduce this system of supercall, where one hospital emergency department would be on call at night on a 1 in 3 basis for the whole south of the city. And that was quite a culture shock to St. Vincent's, which had a very select clientele from Dublin 4 at the time. So on a super cold night, it wouldn't be unusual for me to go out and try and find a patient to see, to have the nurses say to me, oh no, Edna, we couldn't let you see him. We took him off for a bath and a shave, and we'll have him back to you in a minute. So very, very civilized. On a different day, when we weren't on super call, we had one Monday morning when this lassie arrived to be seen, looking like she was in pain, in great discomfort, looking for medical attention and sitting up on one of our trolleys in the busy emergency department. And she explained that she'd stood on an earring and she really needed a cert for work. So I thought, well, okay, I wasn't quite sure how she managed to bag a bed, but I thought, okay, and was preparing to have to extract this embedded earring from the base of her foot. Couldn't find a mark on her. At which stage, I kind of said, you know, what's happened here? It appeared she stood on the back of her earring. So clearly she didn't get the cert and she went promptly home. So very different clientele. But also at that time, again, I don't know if you remember, the late 80s was very much in the early 90s. It was a time of significant cutbacks within the healthcare system. And indeed, we'd been island hopping for about 6 weeks after finals, and I phoned home from a landline in Greece, as you would, to say I was on the way back home, for my mum to say, you all must be really delighted that the strike is over. We were blissfully unaware that there was a doctor's strike that was all fixed by the time we came back to take up our jobs. But the kind of pervasive nature of those healthcare cuts led to many discussions at home, particularly with my brother Damien, around the kitchen table. And I was wondering, was there a better way to approach things in health other than these drastic, across-the-board, single-handed cuts? So it made me think about going back to college to study for an MBA, which Damien had done a number of years earlier. And the idea was that I could learn some management techniques, bring them back to clinical medicine, and maybe contribute to running a better clinical service. And all my clinical colleagues are here today going, can't believe I haven't done that much in terms of organisation in Tala, but it is quite difficult. So it was considered a very drastic move at the time, because business and medicine weren't seen to mix. But back to college, back here to Trinity, and I did the MBA. And it was a fabulous experience. So I got the opportunity to work with colleagues and classmates from all different backgrounds, many of whom came from engineering, and we learned a huge amount from each other, so definitely interprofessional education. I had the great privilege of being taught by John Murray and Dermot McAleese, absolutely fantastic. And after the course, we did, as part of the course, we did a dissertation on the alarm industry. That was my area of study. So if anybody wants to know about passive infrared detectors, perimeter protection, I can have a consultation with you afterwards. So when I'd finished that and finished the MBA, then I decided to consolidate my management training somewhat. And I went to work in Deloitte & Touche, as it then was, PMPA, and then in the Innovation Centre here in Trinity, we were doing a lot of work in terms of optical switching devices. And the idea of that was to kind of consolidate those management skills with a view to going back into clinical medicine. And at that stage, I did the very tough exams for the Faculty of Public Health Medicine. So the idea was that I would come back and train in public health going forward. So I applied to the National Children's Hospital in Harcourt Street to do 6 months of paediatrics to set me on the train. And I forgot to leave, because what happened to me in the NCH was I met Professor Hilary Hoey, who has been my long-term mentor, colleague, and friend, and unfortunately can't be here tonight because she's being awarded somewhere else across the city, which is fantastic. So Hilary introduced me to the concept of diabetes and endocrinology. So I started my postgraduate training in Dublin, moving through the different paediatric hospitals, moving forward and back, and then ultimately came back to Harcourt Street and the move to Tala. So I was delighted to be involved in a number of innovations that Professor O'Connell spoke to us about in terms of, with college at that stage, and was delighted to be Deputy Medical Director when we had that big move to Tala, which was a fantastic success. So medically it was a great success. It was a logistical nightmare, but it was a fabulous success in that even the sickest patients transferred uneventfully. So on the day of the move, the 21st of June 1998, we operated in the Meath and we dialyzed in Tala that later that evening. So it went really, really well without any incident. So for the new Children's Hospital, it's all going to be grand eventually. So after finishing my training in Dublin, I went to do some international training, and you'll see sunny Goodge Street up there at the top. So I went to work as a fellow with Peter Hindmarsh and Charles Brooke at the Middlesex Hospital in London and Great Ormond Street. And during that time, because of the issues and the challenges of adolescent medicine for people with diabetes, it's a real time that they struggle. It's a time where they can fall out of care with absolutely disastrous consequences. I took the opportunity of doing some work in adolescent medicine with Russell Viner in GOS, because they were introducing a whole area of adolescent medicine in London at the time, and that was fantastic. I then spent some time in the States in Sick Kids in Toronto with Dennis Daneman, Kushil Perlman, and Etienne Socket, and was delighted as a committed coffee drinker to see that they had a big retail space in the basement with loads of different coffee outlets. And I thought I could drink coffee till I met Etienne Socket. He would have 3 buckets of Starbucks in a morning clinic, and trying to keep up with him, I just ended up with palpitations. Unbelievable. I then went down to UCSF at Parnassus to work in diabetes and endocrinology, and then spent some time out in UCSF at Stanford in adolescent medicine as well, working with the health van. So what we had was this amazing kind of RV all kitted out, and we traveled to downtown San Francisco to the youth clubs and the basketball courts to try and bring healthcare out to the teenagers. So it was absolutely fantastic, and I couldn't find the picture, which is a real pity, but it was great. It was great fun. It was great fun. Then it was back to Dublin. I was delighted to be appointed in 2004 to the position of a senior lecturer in Trinity, and then I got to pursue clinical diabetes and endocrinology, working with Hilary. And at that stage, we were well established at Tala. And I've had the opportunity of working with fabulous students and collaborators across the board in a lot of rare conditions within endocrinology, thyroid, Prader-Willi, and Turner syndrome, amongst others. So a lot of huge collaborations there that have been really exciting. But what I really want to focus on is a little bit about diabetes. So if we think about diabetes, it was described first by the ancient Egyptians in 1500 BC and noted in the Ebris papers. And they described this idea of passing excessive urine and losing weight. And then in the 2nd century, the term diabetes was introduced, and the idea is that that comes from the Greek meaning to act like a siphon or to pass through. And Aretaeus was very forward-thinking, and he described a melting down of flesh and limbs into the urine, which he felt was underpinning diabetes. Then an Oxford physician, Oxford Willis, noted that the urine was sweet like honey, and he termed the term mellitus, so that becomes honey sweet, which we now know as diabetes mellitus. And I wasn't quite sure what Willis was doing actually tasting urine to find out that it was sweet in the first place. But if you recall, in our early years, we had one of our lecturers bring urine into the class, hold it up, put his finger in it, lick his finger, and then pass it to the students in the front row. The first student declined, passed it to the student beside them, who also declined. The 3rd student then decided that he would stick his finger in the urine and then lick it. Whereupon, yeah, I know, I agree, the lecturer turned around and said, "If you've been watching carefully, this is the finger I put in the container, and this is the finger I licked." What I took away from that was 2 things. 1, observe very carefully to see exactly what you're seeing, and 2, never sit in the front row. So the type of diabetes we look at in children is classically type 1 diabetes, and we know that more than 1 million young people under the age of 20 are diagnosed with this type of diabetes. We don't fully understand what's causing it, but we do know it's an autoimmune-mediated destruction of the insulin-producing pancreatic beta cells. And because you're destroying the insulin production, this type of diabetes is rapidly fatal unless you're treated. And what happens, because you're not producing insulin, the sugar level rises in the blood, and then the body tries to fix it by passing it out in the urine, hence the sweet urine. Because you need insulin to survive with this condition, it has an abrupt onset. It's a short history of maybe 2 or 3 weeks. And currently, although hopefully that's going to change, it's a lifelong chronic disease. It can be associated with long-term complications, but does not have to be. And we can have a premature mortality. What we know about type 1 diabetes, which is really important, is the health outcomes relate to either the blood sugar, or what we call the glycemic control, and the resources that you use. So better resources, better control, you have much better outcomes in diabetes. And to try and understand diabetes better, we need to look at epidemiology, or kind of the study of disease frequency. And what we know is there's a huge international variation in the occurrence of diabetes, with the highest instance in Europe, the lowest instance in Asia, and that north-south gradient with some important exceptions. We know there's a different instance in different ethnic groups, and also there's a migrant effect. And that's really, really important, because what the migrant effect tells us is there's something major going on in our environment that's actually triggering that initial autoimmune process, which is hopefully something that we can modify. So what about Ireland? Well, Ireland was thought to have the lowest rate of diabetes, among the lowest rate in Europe. And clearly on the ground, clinicians felt that that wasn't true. We also found there was no reliable national data regarding type 1 diabetes in either adults or children. And that's why, after much collaboration with clinicians nationally, pediatricians, pediatric endocrinologists, nurse specialists, adult endocrinologists, the Department of Health with HICWA, with the primary care reimbursement services, and extensive collaboration internationally with the World Health Organization and other national registers, we set about developing the Irish Childhood Diabetes Register with a robust methodology. It was a consented registration, which you might feel, of course it was, but back in those days, a lot of the other registers had been undertaken without consent, which meant they all had to close down. So we insisted on consented registration from the start, prospective reporting, and verification of cases. And we're delighted to see that in our 18th year, all national centres still participate and return data, and that's due to the Trojan work of the steering group, and particularly Amanda's intensive work. This is a slide of the steering group of the register, many of whom are here tonight. And it's a fabulous group. They're deeply committed, they're enthusiastic, they're really skilled, and they've expertise in clinical diabetes care, IT, statistics, epidemiology, and advocacy. And as you can see, consistently when we get together, we keep talking and we forget to take a picture. So the last time we said we had to take a picture, but unfortunately couldn't get everyone there. So on the bottom right here, we have Kerry Ryder, who's data and IS lead, research and evidence with the HSE. Next up, we have Hilary Hoey, who's professor of endocrinology and emeritus professor of pediatrics, and the chairman of Diabetes Ireland. We then have Professor Myra O'Regan, professor of statistics, who is here with us this evening, and Helen, advanced nurse practitioner in pediatric diabetes, who is here with us this evening, and Amanda, who has a background in nursing and healthcare informatics, who is research nurse with the register. But the success of the register is due to the inspiration, expertise, and the ongoing commitment of this steering group. So what have we found? Well, what we found is, over the period of the register, a 23% increase in the incidence of type 1 diabetes in our population, an average of a 1.4% increase every year. But we've seen an important periodicity, which is seen in some other registers as well, and that again helps us think about possible triggers, possible causality, and that's where Eurodiab, as you were saying, comes into its own, about comparing these international epidemiological registers. So from our work, we can see that Ireland has a high rate of diabetes, and if you look here at the worldwide global estimates of type 1 diabetes, Ireland is now up in 9th position. So we've the 9th highest incidence worldwide of type 1 diabetes. And on the ground, that makes sense. When I took up my post in Tala back in 2004, we were seeing about 5 times less children than we have nowadays. So I've seen a 5-fold increase in what we're seeing with young people at the moment. And the register has more than 5,000 people registered, diagnosed under the age of 15. And what the register does is it provides those national data for the HSE and for other agencies that they can make decisions about, because up to this we were making decisions in a vacuum. And from my management training, I know that if you can't measure it, you can't manage it. So if we don't know the numbers we have, how can we effect proper treatment and how can we deliver the appropriate care? We provide accurate national data for health planning and effective resource allocation, and the data from the register has been used to underpin the paediatric model of care for diabetes. And accurate denominator data lets us do reliable audit, again improving quality of care. We provide forecasts to improve decision making and allow identification and monitoring of patient subgroups for targeted intervention. And nationally, we have a program where we prioritize insulin pump use or really intensive treatment for young children under the age of 6 with diabetes. And I'm delighted to say it's the data from the register that actually helped us make that case and convince the politicians to fund it. It also allows us to look at DKA rates and DKA prevention programs. We're going to talk a little bit about those later. And we return data to local centres to enable them to support their local audit, because we know a lot of the local centres are still paper-based. And hearing from them, they tell me that a lot of the data they get back from us has enabled them to go to their funders, to go back to the HSE looking for additional staff. So it helps them get local staff. And indeed, a lot of the register work has helped get nursing diabetes nurse specialists across the country where they weren't there before. So numbers really do matter. We also have provided support to national programs like the National Retina Screen and participate in Eurodiab to help us understand what's driving diabetes forward. So if we look at diabetes treatment, it's not been around that terribly long. So insulin was discovered in Toronto in 1921 by Banting, Best and McLeod. And in 1923, Banting injected a crude insulin extract from fetal calf pancreases into a 14-year-old boy, Leonard Thompson. And when he did this, while it worked, there were really nasty abscesses at the site. And if you think about this, this was pre the use of antibiotics, so it was a really challenging time. So their biochemist, James Collip, refined the extract further and continued to use these injections of insulin for Leonard, who survived a further 13 years, which is fantastic. His cause of death subsequently was pneumonia, and again, it was the pre-antibiotic era which caused it. So the insulin worked. But over 100 years later, we're still using insulin. So we haven't moved on that terribly much. Yes, our insulins are faster, they're more physiological, they're better. We've got better methods of checking blood glucose. We used to check urine for sugar, then finger prick glucose, and now continuous glucose monitoring. And we've better insulin delivery methods. We started with syringes, then we moved on to pens, we then moved on to clever pens, and now insulin pumps, or continuous subcutaneous insulin infusion, which is the proper name for the pumps. And we can use those insulin pumps in different ways. So we can use those pumps standalone just to give insulin, or we can use a continuous glucose monitoring sensor that monitors the amount of sugar that's going on in the system. And those continuous glucose monitors can talk to the pump in a limited fashion in a sensor-augmented pump to say, look, I think your blood sugar is either low or going to be low shortly, stop giving insulin. But now we've moved further on. We've moved on to the partial hybrid closed-loop pump, where the glucose sensor talks to the pump, and using a background algorithm that's preset, will get the insulin pump to continue to secrete automatically small amounts of insulin to keep the blood sugar within the predefined target range. So it's really been a game changer. It's absolutely fantastic. And that partial hybrid closed loop pump is getting better and better all the time. At the moment, we do have to tell the pump when you're going to eat, what you're going to eat, if you're going to exercise. But new iterations of the pump are going to make that not necessary. And that's coming very, very soon. So that's really good. And I'd like to draw your attention to the pump at the bottom we have in regular use at the moment. The pump on the right-hand side at the top. Again, the Lisbon card is there to give you an idea of scale. We have that in regular use in children and adults. And the newer pumps, if you look there on the left-hand side, there's a little Toby pump. And the card is there for scale. It's about 2/3 the size of a Leap card. That is already available, licensed and used in the States. We're just waiting on European approval. So they're getting smaller and smaller all the time. We're moving forward to have patch pumps soon and disposable pumps, and maybe even dual hormone pumps, which are going to be even better and even safer. And if you look at the insulin pump as it started on the right-hand side, you see the benefit of innovation. So that pump was like a backpack. It was big enough to put a baby in as well as the pump. So huge changes. So the technological changes in diabetes have been amazing, and they're getting better all the time. And that's really good because we know good blood sugar control has a really lasting impact. So this is the landmark study. You can never give a talk in diabetes without talking about the Diabetes Control and Complications Trial, the DCCT. And that study showed the importance of tight sugar control in diabetes and improving outcomes. And in this study, what they did was they intensively treated with regular doses, multiple daily doses of insulin in one group, and in the other group gave them conventional treatment for a 7-year period. At the end of 7 years, because the intensive treatment was so good, everyone went on intensive treatment. But if you look on your right-hand side of the slide, the impact of intensive treatment in terms of mortality is very significant. So there's a huge benefit in mortality, evident even 27 years later, if you had that initial period of good control. So control matters, but good control also has a really long-lasting effect. So if we move to diagnosing diabetes, well, we can diagnose diabetes by confirming a high level of blood sugar in association with those classical symptoms of drinking more, going to the toilet more. But sometimes those symptoms can be really subtle, and they can be dismissed or not acted on or not perceived. And some children experience an acute, life-threatening metabolic decompensation with their new diabetes, called diabetic ketoacidosis, or DKA for short. And that's generally due to delayed diagnosis. And if we think about the problems of high sugar, when you get DKA, your sugar levels are really, really high. And DKA is a major problem. It's a major stress for children and their families. So if you come in and you're diagnosed with diabetes just because your blood sugar level is high, some of these children don't even need to go on an intravenous drip. They can drink fluids, just get a subcutaneous insulin injection, and they're fine. If you've got DKA at diagnosis, classically you're in an intensive care situation. You've got drips and tubes everywhere. It's really scary for children, it's really scary for parents, and it's very, very stressful. In addition, it is associated with mortality. So children can and do die with ketoacidosis, even in developed countries. And one of the things that causes death is brain swelling or cerebral edema. And of those who get brain swelling or cerebral edema, 1/4 of those will die, and up to 1/3 will have lasting, ongoing problems. So preventing DKA is one of the most important things we can do at diagnosis. It makes such a difference. Even if you have kind of a milder ketoacidosis at the time of diagnosis, we do know children have lower cognitive function later on, and we also see structural and functional changes in the brain later on. So it makes a huge difference. We know that if you have poor control of diabetes, you're increasingly likely to be set on a pathway of poor control for life. or a significant part of your life unless you do something meaningful about it. And also it can increase the risk of avoidable diabetes-related complications in young adulthood. And if you see in the graph here on the right, the people who had severe DKA are in red, mild or moderate DKA are in blue, and those without DKA diagnosis are in black. And on the y-axis, what you're seeing is the average blood sugar control. So if you have DKA, either mild, moderate, or severe, your average blood sugar going forward into the future, your control is less good. So your sugars are much higher, leaving you more likely to develop complications later on. So what we set to do in the diabetes register in Ireland was actually look at, well, what's the diabetes rate, what's the rate of DKA at diabetes diagnosis in the Irish population? Because up to this, we didn't have the data, we didn't know. And when we checked, we found that the rate of DKA was really high in our population and rising. So we set to try and do something about that. And what we wanted to do was to promote early diagnosis of diabetes and prevent DKA. And to do this, we established a collaboration with the amazing students from the Institute of Technology in Tallinn, now TUD, and they're design and advertising students. And they helped and worked with us to develop some materials for the campaign. We worked and partnered with Diabetes Ireland. I'm delighted to see Christine here tonight, who helped us with the campaign. And Diabetes Ireland is the national charity for people with diabetes. We also partnered with children, young adults with diabetes and their parents who collaborated in the campaigns with us. They told their stories. They worked with us and did YouTube videos to try and spread the word. And Novo Nordisk worked with us to support the dissemination of the campaign. And the basis of the campaign, which we call TEST, and I'm going to show you some of the materials in a minute, was to increase the community and healthcare practitioner awareness of childhood diabetes. Because one of the things we did in our research was we spoke to experienced health professionals, and the feedback I got from them was, well, children don't get diabetes, and if they do, it's really, really rare. So they didn't feel diabetes was an issue in children. So what we wanted people to do was think about diabetes. You can never make the diagnosis if it's not even on your list for selection. So think about diabetes. Could this be diabetes? To watch out for the symptoms of TEST and to promote early help seeking. So both in parents, but also in clinicians. And if they had the symptoms, the TEST symptoms, to come forward for testing, either with their GP or the emergency department or the local pharmacy. And if they present in general practice, for prompt referral to hospital. There's no need for additional tests. And one of the challenges with delayed diagnosis in DKA is people get these additional tests that just aren't necessary. So if you think diabetes, just send them in. So these are some of the campaigns that we did. So the T is for thirst, so increased thirst. E is for energy being reduced. S is sudden weight change. And T is for toilet trips. And you might say, well, why did you S for sudden weight change? It's very clunky. And the reason is if we'd said weight loss, we'd get blocked on social media, so we had to find a way around it. So that's the way we did that. So we targeted the general population with traditional media, so interviews, Pat Kenny and all the usual, newspapers, TV and radio. We did a program on social media hosted by Diabetes Ireland with Instagram and Facebook posts and YouTube videos. And then we had brochures, again, explaining a little bit more in depth about the symptoms of diabetes and what to do and the different types of diabetes. And these are widely available to download on the website. And then the poster there, designed to catch attention, but also designed not to be oppressive and scary, because really our message and the message we wanted to get out was, think about diabetes. If you think about it, come forward. There are treatments there, there's supports there. Let's get you started on treatment and move forward. We also targeted healthcare professionals, so medical journals, GP magazines, pharmacy journals, and did a number of GP webinars with more than 1,000 practices dialing in. So the GP webinars, the way they do their CME education is absolutely fantastic. And you get that type of reach with so many people dialing in. We also ran ads in the traditional media, newspapers, TV, radio, and again, social media. And our basis is that everyone potentially has a family member who may come and have the symptoms of diabetes that we need to promote early identification for. So in terms of what happened with the test campaign, the rate of DK had risen up to 46% before the start of COVID. And when we started the test campaign for the first time in 2021, the DK rate had fallen to 43%. So certainly had a huge impact. We've refreshed the campaign, we've rerun the campaign, and we're just reanalyzing the rates for it. But the initial campaign, our target was to reach 1 million people with the message, and we reached 4 million people, so we were really quite happy with that. As Brian said, we have a number of research collaborations in diabetes, particularly with Eurodiab, with Svidar, and you couldn't get put into the group. They had to give you a tutorial on how to say the name before they'd let you join the group. And I'm delighted to say a lot of collaboration with Imelda Coyne from our School of Nursing, who's done some tremendous work in terms of encouraging adolescents' participation in clinic and engagement. But I'd like to share with you the fact that the future is really bright for diabetes treatment. I mean, we've spoken already about the technology and how well that's going to do. And there's been huge benefits from technology. The other thing that we're showing now is islet cell transplantation. And previously, islet cell transplantation was something that was quite challenging. You needed major, very, very major immunosuppression. And with the immunosuppression, you were effectively swapping one disease for another. But now what's happening due to benefits in islet transplantation, we can get a better supply of islets now with new technology, but they're also working with methods of protecting the islets with microencapsulation. That means the islets are relatively protected from immune attack from the body, but can still secrete insulin. So what that's saying is it reduces the need for immunosuppression, and they've recently, with gene editing, have transplanted islets without the need for immunosuppression. And if that happens, that makes islet cell transplantation a very viable option in the very near future. So this has just happened very recently, so it's going to be a very, very viable option. But if we look at other autoimmune conditions, and this type of diabetes is an autoimmune condition, most of the other autoimmune conditions we prevent. So we actually get in early and prevent the immune attack getting any further. And that's what we're trying to do with type 1 diabetes. So if you look at this slide here, what we see as clinical diabetes, how we diagnose diabetes now, is at stage 3. We now have a licensed therapy. It's not yet licensed in Ireland, it's licensed in the US, teplizumab, which will alter that immune response. So children at stage 2 diabetes, where they have the presence of antibodies showing that their pancreas is under attack, and they're not so great at handling sugar. They don't have full-blown clinical diabetes, but they're not great at handling sugar. We can give these children from the age of 8 onwards this immune-modifying agent, which will delay the onset of diabetes for 2 years. So it's the start of, I think, a very good road forward where we will be able to prevent diabetes going forward into the future. So the future is indeed very bright for diabetes. As I draw to a close, I would like to acknowledge our clinical team and collaborators, many of whom are here this evening, for their unfailing support and good humour and all the tremendous work that they do. I'd also like to thank colleagues across the city and across the country. Nuala Murphy is the clinical lead for diabetes, the paediatric endocrinologists, paediatricians and diabetes nurses nationally who've made the register possible. And also our adult colleagues, James Gibney, Kevin Moore, Anne McGowan and Lucianne Bean. Particularly Diabetes Ireland, Kieran O'Leary, Tess Lynch, Kate Goelsa and Christine. And the design and advertising students from TUD, the PWSAI, Novo Nordisk and Abbott Laboratories who support the register. And I have to give a token note to the Adeladies and the Adeladdies from our training days. And we've many photos, but it's often because we're scattered across the world, don't have the opportunity to get a photo of all of us in the one place at any one time. So that's the next thing we need to do. And then I would like to thank my family, and particularly my husband and my daughter Becky, the other sweet child of mine. And thank you all very much for your attention.